What about disparities in cancer care, Jeff? What do you think of that issue?
Well, I think disparities are predominantly created by access, but there are barriers to access, and those can include socioeconomic barriers, language barriers when we're talking about immigrant populations, and then cultural issues. There are some issues with trust with the medical establishment. Those can all be barriers to getting access to care. I think if you remove those barriers and patients have access, that you're going to see most of those disparities go away.
Mike, as a doctor, but more importantly for this question as a payer, you and I know that we could cut the total spend in cancer care in the United States by a lot if we had people not smoke cigarettes and had proper body mass indexes and other things. So how does a payer, or how should we think about and address the comorbidities and behaviors that lead to cancer?
So as oncologists, right, we're at the bottom of the funnel, right, and it's been done, right? So I think the issue from a payer perspective is, and this probably is the primary intent of the quality metrics which have been widely criticized, for example, in the ACO program in Medicare, right? So the idea that if we can improve population health within the ACO by making sure that people get their mammograms, have colonoscopy, have their A1Cs checked, don't use e-cigarettes, monitor their weight. This is a population health management. This is not really an oncologist issue. This is an issue for primary care, and this is an issue for population health.
Okay, great. Jeff, you've been involved in ASCO in a lot of different areas, as evidenced by my introduction. You know, the available physicians, you know, young people going into medicine and then young people going into oncology, you know, with the projection of an ever-increasing number of cancer patients, how do we address this?
Well, in our payment reform session yesterday here at ASCO, one of the commenters was a young oncologist. And he stood up and essentially said, people are not going into oncology because of the uncertainty in the reimbursement system and in their perception that oncology is a place where doctors struggle to be happy. I think that the way to change that is to deal with the payment reform piece. Deal with that in a big way, get it out of the way. Once you get it out of the way, then oncology is going to be a glamour profession. And we've got all these new drugs, there's exciting things going on, there's wonderful science. Those are all the things that people go into medicine for. So why are they not going into oncology? It's not because of what we do when we're in the room with the patient, it's what we have to do when we're outside of the patient and the uncertainty in the reimbursement structure that is keeping people from filling those fellowship slots.
But you know, I think there's an element of delivery reform that actually could, I'm not sure I'd call it a glamour profession, but make it a really fulfilling career decision, and that is team-based care. So I think you guys know I'm a big fan of the medical home model. And one of the core principles of the medical home model is team-based care. And I aspired to that when I was in practice, but there was no scaffolding upon which to execute that. And I think we're starting to come into a universe where, for example, some of my best friends are oncology PharmDs. We will use oncology PharmDs to the full extent of their license. And we will use physician extenders and nurse practitioners and PAs to the full extent. And we will build team-based care. And team-based care diffuses some of the responsibility, but also enriches the career paths of all those people who are part of the team. And I think that's really key.
Okay, great.
I think that'll also attract, if you develop that model, I think that's also going to attract younger oncologists. I've had young oncologists tell me the problem with you as old guys is you don't know how to be teammates. You only know how to be captains.
So the last question of this segment, which is a little bit tricky considering none of us are women, is that, you know, how do you perceive, I'll start with you, Jeff, that there's a rising population of women who are now practicing oncology. How is this significant and relevant to the field?
Well, my first thought on that is Mike's wife is an oncologist. He should answer this question. I think that we are seeing, you know, women enter into medicine in greater numbers. If you look at new medical school classes, many of them are more than 50% female. And I think that enriches and brings a reality to what we do, and is changing some of the paternalism of how we practice in a very positive way. It does create some struggles. I think that's evident not just in medicine, but across the United States, where we've changed from a culture where you have a single breadwinner to two breadwinners, and what does that do to your family life and to relationships?
Yeah, something probably not discussed enough is the impact of being a practicing oncologist on your family life. So thank you. I think we're done with this session.